So, hello, everybody. I am going to speak to you about neoadjuvant treatment for lung cancer and give you the surgeon's perspective. And what I'd like to do is go over the history briefly, because if you don't know your history, then you're doomed to repeat it. And the history starts back in 1994 when Jack Roth came out with his randomized trial of neoadjuvant chemo versus just straight surgery. And this was an important paper because it had a domino effect. Next thing you know, everybody's doing neoadjuvant chemotherapy, and the Roselle, various other trials. So this was going on for the next decade. Give it before, give it after, the Natch trial, pre versus post. So eventually this is what we ended up with. So Le Chevalier presented this at ASCO, and they figured that adjuvant chemotherapy is the best that we're going to get, where you get a 4 to 5% improvement in 5-year survival. And then the LACE meta-analysis came out, where it looked at it for stage 1A to stage 3. And if you notice here, the 1As did better without chemotherapy. So that implies that chemotherapy was doing harm to the 1As. The 1Bs were sort of in the middle, but they included 1Bs in their theoretical use of neoadjuvant therapy because of Gary Strauss's trial, 9633, which at 5 years looked like it was trending to significance, but by 7 years, it was not significant. So this really shows there's no good data to say that 1A or 1B will benefit from chemo. And then this is just to show you the heterogeneity. So stage 3As did better with chemotherapy, but what you got to realize is 3As really without anything are a heterogeneous group. 2As as well, 3Bs as well, but 3As really, you can have a difference of 20 to 40% survival and still have 3A and get the same just surgical treatment, because you can have 1 nodal station, 2 nodal stations, bulky disease, microscopic disease. So a lot of it has to do with your patient selection. The randomization, when you lump everybody into 3A, can be imbalanced. And so it's important to just look at nodal disease. But one thing's for sure that just came out in ASCO was that EGFR mutations treated by tyrosine kinase inhibitors do better. And I don't think there's any doubt about that. When you look at these slides here, they do better. And the important thing to understand from an influence standpoint is not just, yes, this works, so we should use it, but we have to look at what happens when you have a blockbuster drug like this afterwards. So AstraZeneca, after ASCO, after Tagrisso showed this, they racked up $5.4 billion. So that's huge. And so every drug is looked at as, can we get the same return on investment? Now, I just want to touch on 2 studies. One was Howlander in the New England Journal of Medicine that looked at population mortality, and they saw a decline from in 2006 and then over in 2013. And they attributed it to newer drugs to combat cancer. We know that screening decreases mortality. This is the big numbers that they saw. 2006, mortality decreased 3.2%, 2013 to 16 by 6.3%. And they said that these improvements are not due to stage shifts. And when you look over here, early stage cancer is at 10, and then it goes up to about 18 over here. So when I looked at this, I thought there was a stage shift. So we did another study that specifically did the same analysis, and we looked at stage shift. And what we found was that there really was a statistically significant difference where there were more early stage and less later stage. And we published that in JAMA. And the most important result of this showed that tumors were found at a bigger 5 centimeter size than at a smaller size. And this was pointed out to us by Fred Granis, where the take-home message is that a 5 centimeter lung cancer is 20 times more common than a 1 centimeter lung cancer. But when you find that 1 centimeter lung cancer, it's curable and you can decrease mortality. But what we showed was that you decrease mortality was due to stage shift and not to the new drugs. But of course, it got rejected by the New England Journal of Medicine. And then you look at all these other drugs now, and the biggest ones now that were being looked at are the checkpoint inhibitors. Now, nothing's come close to the EGFR ALK influence, but these are doing pretty well. So the question is, now there's this renewed interest in neoadjuvant therapy, and the theoretical rationale behind it is tumor down stages improves resectability. I can argue against that. No matter how small it gets, you still have the fibrosis of the critical areas that you need to resect. It treats early metastatic disease. It helps you assess response. The T cells, the regulatory cells, the memory cells. There's a greater activation of the T cell system when the tumor is in place. All this is theoretical. And many of these were just done on breast and melanoma in rats. And that's how they figured that out. But what does a medical cure really look like? So let's look at where we get medical cures. Germ cell tumor. So you give them this combination, this is platinum-based therapy. You get this, it goes to this, and then we take it out. And we do see the response rates. But does that mean that it's cured? No, you got to look at survival. So here's the survival for germ cell tumor. And the cure rate is pretty damn good, even if you got advanced stage disease. So overall, the cure rate is 90%. We're not even close to anything like that giving drugs. Now, immunotherapy was FDA approved in 2017. And my biggest question, because only about 15 to 20% of patients will benefit from it, is does immunotherapy cure lung cancer? No. We're not seeing any cures with this. You can have longer survival, but can you say that in the Howlander study that the decrease in mortality is because of not just immunotherapy, but targeted therapy? No, we don't cure them with the drugs. So the question is, does pre-op immunotherapy plus surgery increase the lung cancer cure rate? And the most quoted study is Checkmate 816, where you have the two main things. Pathological response, 24% compared to chemo, and event-free survival, which here looked like it was at max at 3 years. And these are what you're looking at with response. And then with event-free survival, stage 1B and 2, not significant. Stage 3A, it is significant. But remember, there's a heterogeneous group of 3As. You can have a 3A with the nodes being negative. That's a cure surgically as far as I'm concerned. And then you can have a 3A with N1 nodes, and you can have a 3A with N2 nodes. So when you're looking to see if your randomization worked, you also have to stratify by nodal disease, not just stage. And when you look at the event-free survival over here, sure. And over here, what's interesting was that there were no deaths in the checkpoint inhibitor arm, which so the question is when you look at the conclusions, significantly longer event-free survival, higher percentage of patients with pathological response, and then this is the one that gets me. The addition of nivolumab to neoadjuvant chemotherapy did not increase the incidence of adverse events or impede the feasibility of surgery. So it did not impede the feasibility of surgery. And that gets propagated from meeting to meeting, from talk to talk, etc. Is that really true? So maybe there was no difference between the two arms, but when you look at surgery, only about 20% in each arm did not come to surgery when they were surgically resectable to begin with. And then delayed surgery, 20% as well in each arm. So you've got 40% who either had no surgery done or a delay in surgery. So this statement did not impede the feasibility of surgery is inaccurate. And when you look at by stage, here you have the early stage, the 1Bs, no difference. Stage 2, no difference. The difference that you're seeing is in the 3As. So is it worth it to give neoadjuvant therapy in 1A or 1B disease when we're not improving anything? And we may actually impede their ability to get surgery. And this was corroborated by Keynote 671, where pathologic response rate 18%. And then this is the group here. But when you look at the placebo group, 5% more N2 in the placebo arm. That can account for this difference that we see here. And the other thing that's interesting is with the deaths. When you look at Keynote, there were 4 deaths in the neoadjuvant group compared to 3 deaths in the placebo group. That makes more sense to me. One more study that was presented at ASCO was looking at pancreatic surgery, upfront surgery versus induction treatment. And what you saw here was the upfront surgery arm did better than the induction treatment arm. 25 months in neoadjuvant versus 38.5 months in upfront surgery. So if we delay surgery by giving neoadjuvant, by taking a long time to get the diagnosis, to run the biomarkers, make sure EGFR, all that stuff is negative so that you can give your checkpoint inhibitor, are we doing harm to these patients? And this was looked at by our group here, by I-ELCAP, that looked at the diagnostic workup and the delay. And what they did is they looked at the diameter of the tumor, classified it as slow growing with a volume doubling time of 240 days, medium, moderate doubling time, 120 days, and fast growing tumors of 60 days. And then they looked at the difference in survival. And what you found was that when you had a 3-month delay for a 4-millimeter lung cancer, you lost about 2%. And when you had at 3 months and you lost 4% at 6 months, and when you look at a 2-centimeter lung cancer and you delay it by 3 months, if it's a fast growing tumor, you lose almost 10% in survival. So does a delay in surgery affect survival? Absolutely. And they're already getting delayed with neoadjuvant treatment. And what if that neoadjuvant treatment isn't working? You're delaying it without any benefit. And if it is working, how much of an effect is it having on the patient? If you have a 1A or 1B tumor that was never going to metastasize anywhere, and it slows that down, and is that really doing anything? You're assuming it's going to get some rogue cell that's systemic, but that's not a guarantee. And so remember, the way I-ELCAP predicted the outcome and the decrease in survival was just by size. They didn't even include, let's say, if a 1.5 centimeter develops lymph nodes. So your survival is probably even worse. So does a delay in surgery affect survival? Not just yes, hell yes. And the question is now, not does immunotherapy plus surgery help, is does pre-op immunotherapy plus surgery reduce the lung cancer cure rate? I'll leave that up to you guys to discuss, but keep another thing in mind is that when you look at the amount of revenue that is being brought in, oncology drugs, $320 billion. Think about that. You can change the narrative if you're an big pharma by investing $100 million, $200 million in advertisements, in changing a narrative that will help your bottom line. And what's interesting, when you look at these huge sums, is that 74% of FDA-approved cancer drugs did not add even a single day of survival, not even 1 day. Remember, to get approved by the FDA, you just need to show there's a response. But 5 years later, when overall survival is no different, it's still past the FDA. I just want us to think about this. If we believe neoadjuvant therapy really is in the patient's best interest, then we need to do it. But if we really believe that this is something that is really driven, whether consciously or subconsciously, by, the drug companies having a larger market share of stage 1As and 1Bs getting drugs who would never otherwise need drugs, we need to keep that in the back of our mind, because we are the front lines. We are the last bit of protection that patients have. And the aim of this argument or this discussion shouldn't be, see, I'm right, you're wrong. No, it's to make progress. It's to make sure that we are checking ourselves and checking the influences that guide our decisions. So the one thing I don't want to give to patients is a distorted hope. You want to give them real hope. And right now, I think there's a misconception about cure rate with these drugs, and not just improving survival. Surgery does cure, and we want to make sure that we don't hinder our ability to cure patients with surgery by pushing these drugs. Thank you, guys.